My dear and esteemed colleagues who have joined us in large number for this series of talks on the challenges of diabetes in India, and I very heartily welcome all of you for this very exceptional sessions which has become very popular. You have made us popular, and I'm extremely happy to be here today once again with a great, very young, very energetic, who has achieved a lot in a very young age. And I'm here talking about Dr. Shankar Dandapani. Dear friend, Shankar Dandapani is one of the youngest endocrinologists of our country, but he had a very, very checkered career, passing out from the Madurai Medical College with lot of honors and accolades. He went to United Kingdom and he got his MRCP. He has worked almost in all the places that you know of. He has been in Birmingham, in Lancashire, in all the famous hospitals. After MRCP, he worked for some time, then went on to do his specialization in endocrinology. He's one of the very few who has got his MRCP in endocrinology from the city of Manchester. After getting his MRCP, he did work in United Kingdom. If you know what is UK famous for clinical medicine, for clinical endocrinology, for clinical diabetology. He worked there for 3 years. He came back, and currently Shankar, I'll call him a first name, much younger to me. Shankar is today a presiding endocrinologist at the Kobai Medical Center in Coimbatore. So, dear friends, let us welcome Dr. Shankar with a big hand. Shankar, I'll be handing over the forum to you. Before that, I'd like to say very few words. You know, diabetes in India is the most important contemporary challenge. The people of India, India as a nation, the health authorities have recognized diabetes as the mother of all non-communicable disease. They have also recognized that diabetes as the numero uno NCD problem in front of the nation. Therefore, we have to dive deep into what are the challenges. Whether we have only the diabetic capital, I think in his inimitable style, Shankar going to describe whether numbers are the what that we want, or you want something beyond the numbers. There is no pride in becoming diabetic capital. There's only pride in becoming diabetes care capital of the world. And he will dive deep into the various aspects of the diabetics, numbers, what we can do, what about the awareness, and awareness can be increased, what really plagues Indian diabetics, and how we can improve it. And he will show us ways and means how we can achieve a lot in India with our available means. And he'll also refer to the current scenario of medication, the drugs becoming very affordable. He will surely, I'm sure, will talk about the combination therapy in which India leads for its compliance, for its convenience, and for its cost coming down. And he's going to give us a discourse regarding the challenges, his perspective. And after he has his short presentation, we'll I will ask him few questions, which in his own style, from his deep knowledge, he will answer those questions for the benefit of me and you and all of us. Dear friends, with this simple introduction, let me welcome Shankar again to give his presentation, Challenges of Diabetes in India. Shankar, all is yours.
Thank you, sir. And thank you for your kind introduction. It's my pleasure to be in the talk with you, sir. Much obliged. Thank you. And dear colleagues, I'm really happy to be with you this evening. And good evening, all. As Professor Dr. Das already explained, the difficulty and the practical challenges that we do have in managing diabetes in India. Right. Why is it so different or so difficult when compared to other nations? Well, there are a few things which is different. It's just the sheer number, the huge volume of diabetic population. And the other thing is about the poor awareness of diabetes. The vast majority of the diabetes people not even know that you are diabetic. And a vast majority of the patients has got a poor control, which most of you will agree with me. Right. In terms of the numbers, can we have the next slide, please? Right. Around 90 million people are living in with diabetes. In India, there is a rule of 50, we call it. Or there are different rules, but this is what I believe. Rule of 50. Almost all of the diabetic population do not know that they are diabetic. And among the people who are diagnosed with diabetes, only around 50% of them get some sort of a diabetic care. And people who get care for diabetes, only less than 50% managed to achieve the target glycemic control. Of course, with a huge number of population, it's not a surprise that we have got the second number of highest diabetic population living in the world. But more importantly, the worry is the amount of pre-diabetes or impaired glucose tolerance test people living in, which put them at a very high risk of developing diabetes. So, what contribute to this sheer number, right? It's quite a few factors and a lot of interplay between these factors because of the increased workload and we running after work, we're running after success. So we spend more time at work and there is a significantly reduced physical activity. And when I was a kid, there's hardly any sweet shops available in my little town. And now every street is blooming with sweet shops and there's a plenty of processed food available. And now you don't eat only when you're hungry. Well, you just cross the road, there's a couple of sweet shops next to your home or next to your school or next to your college. You just, there are plenty of availability of processed food. And of course, because of the increase or revolution in the healthcare, people tend to live longer and that puts the number of diabetic population higher and sedentary lifestyle, increased workload leads to obesity, overweight. So those are the things that driving the huge amount of diabetes. Right. So what about the awareness? Right. Next slide, please. And what is the awareness about diabetes among the patients and the diabetes and the doctors as well? Right. There was a little study that was done to understand about the pattern of diabetes, right? How mainly is about the physician survey, how doctors perceive in terms of managing diabetes and what do they emphasize on, right? And it's quite surprising, around only 1/5 of the doctors do emphasize on HbA1c testing routinely. We all know that the HbA1c test is a gold standard in terms of diabetic management if it was done properly. But around 80% of the diabetic population has not been asked to check HbA1c levels on a periodic basis. If you look at the survey, the doctor's perception, a vast majority of our diabetic population get their fasting and postprandial blood glucose regularly, and in between they have a regular blood test for the kidney functions and the lipid levels and so on. More than 2/3 of the patients have their weight and blood pressure checked periodically and also has had other blood tests, but not exactly HbA1c and other maybe home blood glucose monitoring. Next slide, please. And what happens, right? We don't get an adequate control. So why? Why not? So achieving a very good glycemic control prevents long-term microvascular and macrovascular complications. However, most of our patients struggle to achieve an optimal glycemic control and optimal HbA1c well within the target range due to a number of reasons. The most and foremost factor is poor awareness of the diabetes and its complication. Every time I come across a patient, their general perception is actually the diabetic tablets and the insulin that's causing the kidney damage, not the diabetes. And the other thing is, most of them is not aware of the ideal blood glucose levels target and HbA1c target. Some of my patients tell, what's your blood glucose levels like? Yes, doctor, it's reasonably well. So tell me what it is like. Fasting blood glucose of around 180 and the postprandial blood glucose slightly high at 240. So general lack of awareness about the diabetes, glycemic targets and its complication. And some of the population who come from peripheries and remote villages do have difficulty in accessing healthcare. And of course, in a country like India, where the patient has to pay out of pocket for every test, for a doctor's visit, or for the medicines, they cannot afford. And the part of the problem is the distribution of the healthcare, a proper qualified healthcare professional, is a bit sparse. It's more concentrated in the cities, very lesser in the lesser remote places and things. And of course, social barriers. So this what driving the poor glycemic control. And next slide, please. And how can we manage this more effectively? As we all know, diabetes management is not just about writing the medication and asking the patient to go away. It's a combination of a good healthy lifestyle, a well-balanced diet with plenty of vegetables, proteins, and a lesser amount of carbohydrate, less saturated fat, and so on, and the frequent blood glucose monitoring, and the taking medications on time as advised by the physician, and more importantly, relaxation techniques like yoga and a regular physical activity like aerobic exercise and muscle strengthening exercise. And can I next slide, please? So in terms of diet, what would we advise? What I have noticed, particularly with the Indian diet, when compared to the Western or a Caucasian diet, is we love carbs, right? So my first day, I went from a remote village in India to UK. It was a big move for me. So now my friend took me to a restaurant in London, right? So we went to a restaurant, we ordered some food, so had some chicken and there was some chips. They don't like the word fries, they call chips, right? So my friend said, Shankar, right, start eating. I said, well, let the main item come. So for me, the main item was always a bread or a naan or chapati sort of thing. And he was explaining, Shankar, the chicken is the protein, the fries is, or the chips is the carbohydrate, and the salad is the fiber. So, and just remember the way I ate at home. Plenty of curd rice with potato fry. That's what I, so carbohydrate. So we tend to eat a lot of carbohydrate and a majority of them sort of a processed rice and things. So if we are going to make some improvement in the way we eat, like eating less amount of carbohydrate, and when we choose a carbohydrate, try and choose a carbohydrate with a low glycemic index, like a whole meal, brown rice, or a whole wheat, or ragi, oats, those sort of things. And try and avoid refined food like white rice, white breads, noodles, and so on. And try and make sure we got a plate rule of three. A plate should be divided into three. 1/3 of them should be carbohydrate, which is a complex starch, and 1/3 vegetables, fibers, another 1/3 a protein and a fat. That's what I advise all my patients. And of course, exercise is one of the most important form in looking after diabetes. So I normally advise my patients at least 30 to 40 minutes of aerobic exercise, which means like a brisk walking or running or jogging, cycling, swimming, in most days of the at least 5 days in a week, and at least 2 days in a week, like a muscle strengthening or resistance exercise. And importantly, periodically checking your blood glucose levels either at home or at nearby physician care depends on the type of medication they take. If someone is on metformin only, they don't need to keep regularly check blood glucose level. If someone is on multiple medications or insulin, it's quite vital that they check blood glucose regularly at home with a glucometer or ambulatory blood glucose profile, and they check HbA1c ideally every 3 months or at least twice a year. And importantly, try to stick on with the medications that your physician prescribed And please take it on time and try and avoid hypos, so on. Next slide, please. And what else can we do differently? From the physician point of view, when I was a medical student, I was initially taught that you start on diet and lifestyle for a few months. If it doesn't work, then you start with one medication, usually like a metformin, and wait for the medication to fail for a few years, and then you add another agent. And then, but the problem with this model is you let the patient to remain on high blood glucose for some time and wait for all your beta cell mass to exhaust. So now the emphasis is on an earlier combination therapy initiation. So if the patient is unable to achieve the target glycemic levels with one medication, or if the HbA1c is 2% higher than the target level, you try and go for an initial combination therapy, which will achieve a better glycemic control and of course is going to prevent your beta cell mass from exhaustion. And over the last 10, 12 years, we have all these newer medication. We still should not be calling them novel medication therapy, but these relatively newer medications like a GLP-1 receptor agonist, SGLT2 inhibitors, and DPP4 inhibitors. The advantages with these medications is they are relatively gentle. The risk of hypoglycemia is much more lesser. So you and the patient can be much more happier and you can go home and be safe that the patient is not going to have a lot of hypos. In addition to not just improving the blood glucose level, they tend to have a myriad of other health benefits like protecting the heart, improving the cardiac pumping function, protecting the kidneys, reducing the lipid levels, and so on. So improving glycemic control with earlier combination therapy and try and include this relatively novel medication therapy will go a long way in improving the glycemic controls and more importantly, reducing microvascular and more importantly, macrovascular complications within your medication in the long run. And I will conclude the talk here and hand over the dais back to Professor Dos, sir, and happy to take any questions. Thank you, sir.
Shankar, it was a fabulous talk, and I have no words to express my appreciation and adoration for this wonderful talk. Let us start discussing from where you left. Shankar, you must have seen the recent paper from the Chicago Journal of Diabetes Care that what matters for the diabetes long-term preventing complications is the first year control. When you diagnose diabetes, the first year control matters. You know why
Yes.
they say that, Shankar? They say that you tell them legacy effect. Legacy effect after 10 years. Patients, okay, 10 years, lot of time in my hand. You tell them, no, what is important is the first year control. And they found, they have investigated 34,000 patients, and they found that that people who were 6.5 to 7 their H1s in the first year had much less complication and nil death at the end of 13 years. Where in contradistinction, those who had first year control here, they had lot of complications and had about 3% mortality. So
Yes.
as you rightly said, gone are the days when we are going for the sequential therapy. Start diet, then give exercise, then give one drug, two drug, three drug. That is over today. We have to establish, as you rightly said, early, I call it, don't call it aggressive, early adequate control. First year control, immediate control, and that matters. Now,
True, sir.
what is your opinion, Shankar, is regarding this drugs that we're using today? Would you like to say that the SGLT2 inhibitors should be used much more than they're used today? Maybe they can be used first on a foundational drug of metformin. What's your comment on the use of SGLT2 in our country? But Shankar, I will like very brief answers so that I can take up more questions. We have total time of 35 minutes, so we can answer very briefly. What's your advice regarding SGLT2 inhibitor use? I think they are not penetrated each part of the country yet.
Right, sir. So from my perspective, and also if you look at all the latest guidelines, So if you can introduce SGLT2 inhibitor even as a monotherapy, even before metformin. But of course, I love
Absolutely.
metformin. Sir. I love metformin. Metformin has been market for so long. I still would advise all my patients diet, lifestyle, metformin. And
Yeah.
then
I
when you
said
try to
combination
choose,
for me over and above that SGLT2.
exactly, sir. But when the patient has got other comorbidities like cardiac problems or renal problems or any sort of albuminuria or any LV dysfunction or anything, I would like to use SGLT2 inhibitor compared to traditional sulfonylurea or anything, sir.
Yeah, I think
So,
great answer. And therefore, Shankar, there is a move in the country today to make SGLT2 appropriately used. The reasons
yes,
are two, Shankar. One is that Indian diabetics are ethnically prone to cardiac risk factors,
yes, sir.
and they have much more cardiac morbidity. At the same time, at the same time, the price of the SGLT2 inhibitors and for that matter DPP4 inhibitors has dropped down. I call them
Yes.
forays. They become affordable and they're
Yeah,
appropriate. You rightly said they're
true.
very appropriate for the CRM, cardio-renal metabolic benefit,
Metabolic
benefit on
benefit.
the weight loss, NASH benefit, and a host of benefit.
True,
At the
sir.
same time, they are accessible and available in every nook and corner of the country. They are available today. Dapagliflozin available everywhere. So I think it becomes very easy for us to use the drug very adequately. Now, the other thing I would like to ask you is your passion for the diet and exercise. I'm really amazed. Many in India today do not consider diet and physical activity as a very important facet of diabetes control. What's your message to the people? What is a very simple advice regarding the diet and physical activity for the Indian diabetics?
Right. So, I'll I have to use a few words in Tamil, right?
Yeah,
So what I
please.
tell all my patients is a roll of hand. Okay. So all my patients, I tell, right? A small handful of rice. This is the usual thing. Handful of rice, two handful of vegetables, and
Wow, beautiful.
just a thumb size oil. This is what I recommend all my
Pinch of,
patients.
pinch of oil,
Yes.
minimal. Fantastic. I think it's a great advice. As you rightly said, one of our basic problem is high fiber diet. I mean, high carbohydrate diet
Okay.
and less fiber. So what we need today, as you rightly pointed out in your lecture, high fiber at the same time. I mean, brown sugar, brown bread. We need brown rice. We need the vegetables, which has lot of fibers. I think you have given a very short time, very clear cut advice. And carbohydrate did not fill up your plate. The carbohydrate, there are some people who have said, let us start food with the protein. Let us finish up the dal first. Let us finish up the vegetables next. Let us fit, if you are taking some non-veg food, let us take that. Come to the rice at the end. So automatically the carb will come. There's one of the thoughts, but you rightly pointed out. And also you said, Shankar, I watched your word, that every stage of diabetes, in the entire continuum of diabetes, the physical activity and diet has a role to play. Would you like to highlight at this stage very briefly? I know it's very difficult. Your diet advice to diabetics with early kidney disease, to diabetics with early heart disease.
Yes, sir. So every time I mention about exercise, most people they come up with an excuse or probably sir, I don't have enough time to do exercise.
Yeah,
That's what I find. So, but in practice, it's not that difficult. You don't need to go to fancy gym or you don't need to get a membership and pay 2,000, 3,000 per month for a gym membership. All you need is a little shoes and you can just walk down the road briskly. You don't need
absolutely.
any time. Exactly, sir. So 30 minutes is not a lot of time. All you have to do is just wake up for 30 minutes earlier. Instead of 5:30 or 6 o'clock, just half an hour earlier will make a lot of difference. And you will feel a lot more energetic. It's just the
I
exercise.
think that's a great message, Shankar, that even 30 minutes, and you cannot forget to carry your legs, Shankar, wherever you go, Coimbatore to Madurai, Madurai to Chennai, you cannot forget to carry your legs. So if you walk for 30 minutes to 45 minutes, brisk walking, it is good enough. And as you rightly said, it gives a great sense of well-being. As you rightly said, feel good factor is great for the exercise. I watched something you greatly said about measuring blood glucose and HbA1c. Will you dilate upon that? because people are not measuring their blood glucose, not measuring HbA1c. Whatever the reason, I'll come to it in a minute. But what do you think? How often they should do it and why they're not doing it?
I think it's just mostly the lack of awareness, sir. Probably my prescription nowadays contain more glucometer prescription than medication prescriptions, right?
Absolutely.
And I have seen them, the way they transform the blood glucose levels just by simple monitoring.
Absolutely. It is doctor's tenacity of purpose. I always tell my patients, Shankar, a very simple message. I said, I want to improve the quality of blood glucose control. I can only improve what I measure. If you look the quality cycle, it is measure, improve, and then you get the improved control. So I have to measure. If you do not measure blood glucose, if you do not measure HbA1c, which is a very vital sign, forget about time in range. That is important, but at least HbA1c, fasting and postprandial glucose, how can I improve your diabetes? So that's a very great message you gave, that we have to measure the measurable items and also look for the cholesterol, look for the blood pressure. You can only improve what you measure, and in measuring is inherent the improvement. So that's a very great message you gave. I'm really delighted about it. Now you said something very, very important, that you gave. I was watching 7 messages to improve diabetes in India, and for the audience purpose, I would like to repeat those messages, which are very simple, Shankar. You said diet and regular exercise, proper diet and regular exercise. The ideal diet is a good diabetic diet. You believe so? A good ideal say diet. May I add a South Indian diet, or may I add even a North Indian diet?
Okay.
A good Indian diet is a good diet for the diabetics, and regular exercise. Second, you said keep an eye on the blood glucose level. You said that. You have to be careful about blood glucose. And you know what I call it? I call it the 5th vital sign. Like pulse, BP, temperature, respiration, the 5th vital sign is blood glucose. You cannot forget it. Keep a tap on that. Third, you said regular with the medication. I remember that English joke, Shankar. In our time, Professor David Pike used to say, medicine do not work. When people don't take them. So you have to be careful about your medication. People in a chronic disease, people forget about medication. Third, you have to control your cholesterol. I do believe you have wonderful drugs. We have wonderful agents for containing the lipids today. We have the statins, which have in this scenario control 1/3 of the heart attack. Fifth, you take care of the kidney. And there are drugs today, like SGLT2. Let me be very frank about it. SGLT2, like other drugs, which can take care of the CRM, cardio, renal, metabolic aspects. You also said lose weight, and losing weight happens with SGLT2. More weight with GLP-1RA, which is injectable. Oral is slightly overpriced, priced more, but you can lose weight with SGLT2 also. And finally said you must practice good oral hygiene. I'm absolutely delighted that you gave the simple message, which was very important. Last 3 points I will ask you. Now, what's your message to improve diabetes control in our country? We use this word, Shankar, in one of our JAPI editorial, me and Shashank Joshi, that sheer numbers. We wrote about diabetic foot. You can see in JAPI. Now we said, how do we improve diabetes control? Our reason for existence, Shankar, as you rightly said, we are practicing diabetes because our main objective is to improve control. So what's your message to the healthcare providers? What's your message to the person with diabetes in improving control?
All right, sir. The most important thing is that you need to make aware that they are diabetes and change their perception that a slightly raised blood glucose level is perhaps acceptable, which is not. This message goes both to the physician and to the patients, that any amount of high blood glucose is detrimental. So try and keep the blood glucose level well within the target.
You from here, you live longest if your sugars are low. Absolutely
Yes.
correct. Continue.
Exactly.
Continue. Please continue.
And also, a regular blood glucose monitoring is vital. So I have seen a lot of patients, once they get the blood glucose meter, they check blood glucose levels and they come back. Yes, sir, as you said, the blood glucose levels are high. And once they started monitoring, they know it's high and they will adjust the therapy, or they will just contact us. They will increase the insulin dose. And the next time they come back after 3 months, they are a happy person. Yes, sir, it's a lot better. So they can see the results in front of them. by frequently monitoring.
I think great message. You can only improve what you measure. And today's availability of the glucometers have made it very easy. And also, I must tell you again, I'm saying the same point, that availability of the drugs today with a very affordable price, say DPP4 inhibitors, say
Yes,
the
sir.
SGLT2 inhibitors. And
Inhibitor.
India is a market of combinations. We have the metformin SU combination, we have the DPP4 metformin combination of the Verify trial, we have the DPP4 SGLT2 combination, and multiple combinations. These combinations in India have given us three things, as I said at the beginning. They have made the drug price little less, cost has come down. The compliance of the patient, the pill burden has come down, so compliance is better, and it is convenient for the patient. So, and the countries like United States and UK, and also the Sri Lanka are following us. They are going to introduce the FDC market in their country. So we must approve this. You said something very important. You know, there is a divide in our country between the urban and the rural areas. There is a divide. You rightly said that there is a financial constraint. But what is most constraint to my mind is that the out-of-pocket expenses for the Indian diabetics is about 69% pay out of pocket. Only 31% in the government surveys, some insurance and all that. So it is very important to give maximal benefit with the minimal drugs that we have in the armamentarium. And from
Yes.
that point of view, this combination, SGLT2, DPP4, metformin, SU, they work out extremely well. And the money we save can go to give antihypertensive, anti-lipids, and giving the drugs to keep the blood thin when necessary. So it is very important to maximize the treatment benefits with the available oral drugs that are very easy today. I call it very affordable and available everywhere in the country. And you also say, there's a talk, the 9 by 10 paradox. The 90% of the medications, diabetic medications or budget is utilized for 10% of the people in the northern hemisphere. Only 10% of the budget comes to the countries like India and other
Mm.
third world countries. And out of this 10%, majority comes to the towns. The villages do suffer. I'm very happy you touched upon the point. It is the duty of the government and the duty of the society, duty of all of us to take care and maybe remove this division. Now, before I close, I have to ask you one thing. You rightly said that you quoted two studies, the ICI studies, and quoted the very famous HB1C. I was the chairman of the study, Impact India study, and you
Yes,
said
yes.
that one third only is aware of the H1C, two-third are not. And you also said that the awareness about the glucose management, H1C 19%. You said about the weight management, only two-third new weight is bad. So we need a great deal of things to change the scenario in the country. Uh, Before we close, would like to give some simple message to the audience. We have got 2 minutes left. Shankar, any simple message to the audience?
Okay, sir. Managing diabetes is not that complicated as we think. It's
Correct.
the right mix of a healthy, well balanced diet with
Correct.
a less saturated fat, plenty of vegetable and fiber, and at least 30 to 40 minutes of brisk aerobic activities daily, and taking medications on time, on regular consultation with the doctor, will get your blood glucose levels and improve your health and avoid long term complications in the long term. Thank you.
Thank you. Before I close, dear friend, the Sankar's message has been loud and clear. He spoke about the lifestyle. And in India, which has a great culture, lifestyle is embedded in our culture. And we must have a positivity. We must say diabetes is not a disease, a syndrome. A good, well controlled diabetes is better than a non diabetic. We should try to control blood glucose well. And all the other parameters he described very well. We become better than non diabetic. He said about the positive approach, a positivity that way I can do exercise, I can control my blood glucose, I can do diet. And he said in his practice, he has shown today people come back with better numbers. And also, I must like to mention what he did not say, but what was in his mind, that like UK, we must have a cadre of diabetes educators and diabetes specialist nurse. Remember, Shankar, your days and my days, when the diabetes nurse used to control maximum things. And before
Yes,
I
sir.
close, am I correct? Before I would
You
like
are.
to say something. Is very
No, no,
important. We
no.
must have
You are.
a cadre of diabetic educators, diabetes specialist nurse. And I must tell you that today's diabetes management must be total 360 degree. Not only glucose control, caring for the heart, caring for the kidney, caring for the weight, caring for the NASH, and then we'll win the battle. Shankar, having with us has been great. I'm sure I'll get back to you once again for many programs. I'm delighted with your wide knowledge, your simplistic approach, and the way you have given the quality messages for the masses. Thank you very much. A big hand for Dr. Shankar Dandapani.
Thank you, sir. It's been my pleasure and privilege to be with you today, sir. Thank you.